So it's a pleasure to see so much people today, and good evening. I am Jacques Cadranel, working at the head of Chest and Thoracic Oncology Department at the Sorbonne Université Hospital in Paris, France. I am a thoracic oncologist, which is particularly involved in some aspects of lung cancer translational research. On behalf of the ERS Thoracic Oncology Assembly, it is a pleasure to participate as a chairperson to this ERS webinar on challenges in the management of small cell carcinoma, and to introduce our two speakers and experts of the field today. That is first Dragana Jovanovic, who is full professor in pulmonology and thoracic oncology. She's working at the Department for Thoracic Oncology and Interstitial Lung Disease at the University Hospital of Belgrade in Serbia. In addition to being a thoracic oncologist, she had developed the palliative care medicine in her country. She's particularly involved in the ERS activities, and especially in the Thoracic Oncology Assembly and the different task force aiming on quality management or standard harmonization of lung cancer care in Europe. She's author of about 200 papers. Second, Thorsten Gerriot-Blum, who is our famous and dynamic current secretary and head-elect of the Thoracic Oncology Assembly within the European Respiratory Society. He's also a thoracic oncologist and is working in Berlin, Germany at the Lungenklinik Eckerson within the Helios Klinikum Emil von Behring. Perfect. Particularly involved in the several ERS task force within the scope of quality improvement in lung cancer care in Europe. He has been recently granted for a 3-year ERS clinical research collaboration program, and maybe he will speak about in few days or weeks. Finally, apart from us, we will be more than 100 participants to this webinar. Therefore, it is of importance that we will have many interactions through the chat or after answering some short surveys that has been prepared by Thorsten Blum and commented by Dragana. The general idea is to go through the various subjects which pose us difficulties, starting from epidemiology and diagnosis approach to disease extension management, and finally therapeutic management from localized to extensive small carcinomas. So Dragana and Thorsten, do you have something to add, or you can run directly?
Well, for the sake of time, welcome to all, and I hope they will all enjoy this seminar. So just that to say, because we will have time to discuss more. Thank you.
So go ahead, Thorsten.
Yeah, thank you very much, Jack. So warm welcome to everybody. And Ali, can you give me control, please? So
just click on the screen.
And thank you to Ali.
It's currently not. There we go. Okay, so here my conflicts of interest just go back. So the topic of today is the challenges in the management of small cell lung cancer, sometimes the somehow forgotten lung cancer subtype. And this is a webinar. It's supposed to be interactive, as Jack has pointed out. So the idea is that we have certain topics, and at the end of each topic, we will have time to discuss things. I've prepared some, let's say, warm-up questions where you can just poll your answers. Here are my conflicts of interest. And now I try to click. There we go. So we start briefly with epidemiology. Small cell lung cancer is the third most common lung cancer histology, as you can see on the right figure, following adenocarcinoma and squamous cell carcinoma, depending on which country you're living in, depending on the smoking habits in your country. It's something about 12 to 15%. So in Germany, for example, it's 15%. Here you see the SEER figures, and for the period 2019 until 2018, it was 12.6%. Small cell lung cancer belongs into the group of neuroendocrine tumors, and this is the overarching topic of these 2 or potentially 3 webinars that Dragana has kindly set up. So today we will start with the small cell lung cancer, but there are also neuroendocrine carcinoma of the lung other than small cell carcinoma, and this will be the topic of the next webinar in June. Small cell carcinoma has 2 subclasses. So there is the small cell carcinoma, as you can see here, but there's also combined small cell carcinoma containing at least parts of non-small carcinoma components. And this is about 10 to 30% of all small cell lung cancers. And very important, there is a very strong link to smoking. In fact, it's the strongest link in all lung cancer subtypes. So only 2% in small cell lung cancers have been never smokers. All the others used to be smokers. So let's start with diagnostics, and here's the first warm-up question. As you are probably aware of, small cell lung cancer is the most deadliest subtype of all lung cancers. And I think we are also all aware of that there will be population-based lung cancer screening programs with low-dose CT within the next years in Europe. There has been a Nelson trial, as you can see here, with different intervals. So this may be a good thing to detect small cell lung cancer early. So my first question to you is, based on your knowledge of the Nelson trial, what do you think that the subgroup of small cell lung cancers has the highest relative proportion of screening detected lung cancers compared to the other subgroups? So will screening pick up small cell lung cancers really good? Or is it the opposite? Option number 2, it has the lowest relative proportion of screening detected lung cancers. Or is it option 3? It doesn't matter what the histological subgroup is. It's all the same, independent of histology. So please click and then confirm. And then after some seconds, Ali will kindly present the results. Okay, it has the lowest relative proportion, so this was the majority. It was somehow close for 49 to 37%, but answer number 2 is the correct one, as you will see now. This is the table, the results from the Nelson screening trial, and here in these columns we have the findings from the screening group, and here at the left, those were the cancers that were detected by screening, but there were also cancers that were detected in between, independent from the screening program. And here you can see just an opposite correlation. So adenocarcinoma was the subtype that was picked up best. So almost more than 2/3 of the adenocarcinomas were picked up by the lung cancer screening. And just the opposite for the small cell carcinoma, 2/3 were not picked up by the lung cancer screening. And I think the explanation for that is that Small cell lung cancer is so aggressive, as so a fast-growing tumor that come apparent in between the screening intervals. So we have to keep this in mind, that lung cancer screening per se is a good thing, but it may have problem to pick up small cell carcinoma patients well. So how about signs and symptoms of small cell lung cancer? So first of all, the vast majority of primary small cell lung cancers is located centrally, perihilar or invading the bronchial peritracheal structures. And only in the minority of cases you will find a solitary pulmonary nodule based on the epidemiological data. Local regional lymph node metastases are very common, and they are often very large, also causing problems, as I will show you in some seconds. And unfortunately, at the stage of diagnosis, in the majority of patients, we will already see distant metastasis. So about 2/3 up to 80%, also depending on where you live at the time of diagnosis, are presenting with distant metastasis. And locations are brain, liver, the bones, adrenal glands, and also distant lymph node locations. Based on these properties of small cell lung cancer, you can, I think, very well explain the symptoms. So if you have endobronchial infiltration and growth, there will be cough, there will be dyspnea. You will hear, as a physician, stridor or wheezing, and sometimes patients already present with hemoptysis at the time of diagnosis. If it comes to the mediastinal infiltration and growth, there will be somehow local compression complications, like the compression of the superior vena cava. There could be hoarseness, diaphragmatic palsy and elevation if nerves are compressed. If you have infiltration of the pericardium or the pleural space, you will already see effusions. And of course, you will find patients that complain about pain, which somehow can also affect the shoulder and somehow distract us from thinking of lung cancer at the very first time. You will also find distance, enlargements of lymph nodes, and if it comes to metastasis, you can see here the sometimes specific, sometimes unspecific symptoms of the different metastatic locations. So here's my second question, because this is something that you will surely also encounter in small cell lung cancer, perineuroplastic syndromes. Are they, option one, less common than in non-small cell lung cancer? Or option two, have they often only limited clinical relevance? Or option three, they should not preclude tumor-specific therapies with curative intent. Or, last but not least, option four, they occur predominantly in the terminal phase of small cell lung cancer. So please pick the correct option. So there's only one which I think is correct. Okay, we are waiting for the results. There we go. That's fine. So I think 60% have chosen the correct option. And I think that's the first very important message. And this is, of course, not only true for small cell lung cancer. Perineuroplastic syndromes should never, ever preclude us from providing tumor-specific therapies with curative intent, because if you treat the tumor specifically, you have a good chance to also solve perineuroplastic the problems with deriving from perineuroplastic syndromes in non-small cell lung cancer. And here in this review article, very recently published last year, you have a, I think, nice overview of the different types of perineuroplastic syndromes, specifically in small cell lung cancer. So SAA-DH is the most common one, and 15%. The finding that you will see in the lab is hyponatremia. Patients can become rather soon really symptomatic, as you can see here, up to seizure, up to coma. Then followed by the Cushing syndrome. But let's also not forget about a variety of neurological neoplastic syndromes, most often driven by specific antibodies, as you can see here in the table. The Lambert-Eaton syndrome is, I think, one of the common ones among the neurological perineuroplastic syndromes. And finally, as we also know from non-small cell lung cancer, we could face perineuroplastic hypercalcemia, so not directly derived from bone metastasis, but from the related perit hormone, and sometimes also lethal thromboembolic events could be caused due to perineuroplastic syndromes. What is the workup? And I have chosen the NCCN guideline from the United States because it's the most up-to-date one. Well, you can see here there's a lot you should think of if you are facing a patient with small cell lung cancer, or having a patient suspected of having small cell lung cancer. As pointed out, history and physical examination is really important. Blood work can help you to pick up perineuroplastic syndromes. You need proper imaging from the chest down to the pelvis. PET-CT does play an essential role. I will talk about some slides later. Brain MRI, really important, should be preferred over the CT of the brain. Bone scintigraphy has its place if no PET-CT is performed. Then when it comes to the confirmation of the tumor, histological or cytological sampling, and leading to a proper pathology review, including molecular profiling. And you could sometimes also think of bone marrow aspiration or biopsies, and I have listed states or circumstances that may think that the small cell lung cancer has already invaded the bone marrow, and which should lead to this specific diagnostic tool. Pathological review should be based on the WHO tumor classification system. This is the basis. And the good news is that if you have proper samples, then you can already use the light microscopy, H&E staining sections, to diagnose small cell lung cancer. One essential piece of your pathological diagnosis should be the counting of the mitosis. As said, small cell lung cancer is a fast-growing tumor. Accordingly, you will see a lot of mitosis per eye field. So if it's more than 10 mitosis per 2 square millimeter field, then this is really pointing towards non-small cell lung cancer. If it's less or far less, then it's more pointing to carcinoids, typical or atypical ones, which can sometimes impose problems in making the right diagnosis. Immunohistochemistry is also very useful. You have different antibody listed here, staining specifically cytokeratin structures or neuroendocrine markers. You have the thyroid transcription factor, TTF1, which is positive in 85 to 90%, which can help you to discriminate from primary extrapulmonary small cell lung cancers. Key 67 is a proliferation marker, and it's really high, one of the highest values in lung cancers, and also helping to discriminate from carcinoid tumors where it's far lower. Staging, that's another aim in the diagnostic phase, because the stage, as we will learn later, will determine the kind of treatment. And more than 40 years ago, I think already in the 1950s, the Veterans Administration Lung Study Group introduced a still used two-stage classification scheme, discriminating between limited stage or limited disease from extensive stage or extensive disease. And the original idea was that because in the 50s and 60s, radiation therapy was one of the only measures to treat small cell lung cancer, to find a maximum amount or fraction of small cell lung cancer. So our predecessing colleagues defined limited stage or limited disease as confined to one hemithorax and without any extrathoracic metastasis, except for ipsilateral supraclavicular lymph nodes. So again, the idea was to squeeze all into a meaningful radiation field. And in contrast to that, extensive stage is defined as a disease that cannot classify it as limited disease anymore. Specifically, if there are malignant pleural or pericardial effusions, or more distant lymph node affections, or even distant hematogenous metastasis. In 1989, SCLC has slightly modified this traditional two-stage classification scheme, and now limited disease also includes contralateral mediastinal or supraclavicular lymph node metastasis, and even ipsilateral pleural infusions independent of cytology. So it was a bit more including local tumor manifestations. It's still somehow problematic or still debatable how to classify contralateral supraclavicular or a contralateral healer lymph node involvement, so be it limited or be it extensive disease, this is somehow interpreted controversially. Then in 2009, with the 7th edition of the IRCC or UICC staging system, the TNN system, which made up this IRCC staging system, was also applied to small cell lung cancer. Before that, it was only applied to non-small cell lung cancer. This has also been followed this approach with the new 8th edition of the UICC version, as you can see here. So in this figure and this table, this is the 7th edition, and this, as you can see here, with the far more groups that have been introduced with the 8th version. Here are the specific figures, outcome figures, overall survival figures for small cell lung cancer. And in the early stages, 1 and 2, as you can see here, this system is based on rather low patient figures. Accordingly, they do not discriminate rather well, but in the more advanced stages, 3 and 4, you see that the Kaplan-Meier curves discriminate well. And here you can see a really broad range of 2-year overall survival, ranging from 93% in stage 1A1 up to a devastating 8% after 2 years in stage 4 small cell lung cancer disease. And you can translate this back into the old 2-stage system, limited disease, extensive disease, as you can see here with the according TNM system values. And sometimes, at least in Germany, we have a 3-stage system, so we also discriminate in very limited disease, and this is limited to small primary tumors with only healer lymph node involvement, or better, no healer lymph node involvement at all. Then, if it comes to clarify the staging over the last decade, and this is of course true for all lung cancer subtypes, PET-CT has somehow revolutionized the staging, and this is also true for small cell lung cancer, as you can see here in this nice review article by Karl and Kirian from 2013, and they have pooled prospective but also retrospective observational studies. And as you can see here, the stage concordance between PET stage patients and only CT stage patients was only 89% in the prospective studies, a bit lower in the retrospective studies. And the PET and the PET-CT helped to better discriminate or really diagnose whether a limited stage is present or already an extended stage is present. So the level of upstaging was 17% in the cohort of prospective studies. And the opposite way, it also helped to correctly downstage small cell lung cancers in up to 5%. And if you pool retrospective and prospective studies, The upstaging based on this value was 18%, and the downstaging from extensive to limited disease 11%. And this has a clear effect on the treatment, the proper treatment of patients. So PET helps to find better management of small cell lung cancer, be it if you use it to define your radiotherapy field. I think we are all aware of this new modern radiotherapy topics where PET-CT is a cornerstone in planning the radiotherapy fields, but it also helps, of course, in finding proper treatments. Based on this review, 15%, because the discrimination between limited and extensive disease is crucial to define the proper treatment. So, question 3 to you: in newly diagnosed small cell lung cancer, so you use PET-CT in all cases. Option 1 or option 2, you use PET-CT only in those cases where you suspect limited disease, but you are not sure, so the stage is uncertain, so you would need the PET-CT to clarify the stage. Or, and this is somehow relating to a resource problem, you would like to use PET-CT in your individual setting, but you do not have access in a timely manner. So please use your option. Okay, 63%, and I think this is correct. But you could debate if you could also use to perform to use the PET-CT also for the staging of the M status, the FM discriminator. So this is somehow debatable. And in practice, I think the timely access, especially in a fast-growing tumor like small cell lung cancer, could impose a problem. And here we have time for the first discussion. So Jack and Dragana, maybe you can somehow collect the questions from the audience, or you have certainly your own questions, so that we have some discussion on the diagnostic part.
Anna, could you begin?
Yes, I don't see now many questions. I don't see them in chat room. So could you help me a little bit?
So then I have the first question. So in
Yes.
your setting, do you have problems to find timely access to PET-CT?
Yes.
Sometimes it's here in our place, it could be a problem. So it's of course not a matter of weeks, but sometimes it's a dangerous mediastinal complication, and we sometimes would like to have a PET-CT fast, but sometimes we simply do not get it. How is it in Belgrade, Dragana?
Well, Belgrade, unfortunately, many times we don't have timely access to PET-CT, and that is really a very important question, especially if our thoracic surgeon consider, for example, the case of small cell lung cancer as a very limited one. So they are very much interested first, as a first step, to perform operation. So that is one occasion that is really important. So we rely on CT scan, and also we rely on adequate mediastinal staging, which means thorough examination, bronchoscopic, with IBUS and ES. So having the samples from also by endobronchial ultrasound, but also as a phageal ultrasound.
There are two questions in the chat. The first one is on the place of surgery in small cell lung carcinoma, but it will be see after. And there is usually no place for the diagnosis. It's a surprise when you have a nodules and look at it. It's a finally small cell lung carcinoma. I think there is no place for the diagnosis, but maybe some place for the treatment. but we will speak about later. And the second one, it's about the optimal time frame to diagnose small cell lung carcinoma and start treatments. Role of invasive staging, EBUS, EUS, mediacy of lymph nodes with a distant metastasis. Torsten?
So for the treatment interval, I think I can answer because we currently, Dragana and me are working in a, well, somehow never-ending task force on various aspects of quality of lung cancer care. And one is waiting time, and we have explored the treatment interval. And there was somehow a paradox effect in the subgroup of small cell lung cancers. So in patients with small cell lung cancer, if you wait longer from the time point of diagnosis to the start of treatment, they have a longer overall survival than those where you start treatment much earlier, where you have a shorter treatment interval. But I personally think this paradox is simply a bias because, as we know, in such a lethal disease as small cell lung cancers, you have a large proportion or significant proportion of patients that whatever treatment you provide to them, they unfortunately will die anyhow. So I think these are the patients that are causing the poorer overall survival in the short-term treatment interval. So that's, I think, could be an explanation for this paradox of the waiting times.
I would like just to add something, Jacques. You have told that there was a question about surgery in diagnostic for diagnostic purposes. I would just like to add something that it is possible. For example, in 4 to 12% of solitary pulmonary nodules, they are small cell lung cancer. So then they're operated as of unknown origin, and then after operation, we get this diagnosis of small cell lung cancer. It happens. It's really rarely, but it happens.
But usually the diagnosis of a small cell is easy by bronchoscopy because biopsy are always almost positive and not difficult to diagnose. And also EBUS and EUS is also very, very effective for the diagnosis. So in almost all cases, the diagnosis is not really a problem.
Yes.
Yeah, I think so too, because it's mainly located centrally in the majority of cases, so it could be reached rather easily.
Is there a place for some patient to have a molecular analysis in case of small cell lung carcinoma?
Yes, I think if you ask me, I think there is a place for molecular, for example, analysis. For example, it is very important if you have EGFR patient that it becomes resistant, and then you have transformation to small cell lung cancer. Yeah. And then usually you can, in fact, have the situation that is very important. It is a small percentage, 3 to 5%, but it is important in those cases.
So don't forget to make molecular analysis in non-smoker with small cell carcinoma.
Yes.
Yeah, I think it's also important if you have combined small cell lung cancer to properly describe the proportion of the non-small cell lung cancer.
Yes, Dragana, sorry.
No, Torsten started. Do we have some questions more? Okay. This is about hypercalcemia.
How frequently, yes, a question also, how frequently small cell carcinoma is detected as very limited?
Less than 5%.
Yes, only several percent.
Very unusual.
Yes.
Yes. So you have to be lucky as a patient.
And do you know also, Torsten, finally the preferential metastatic sites that are better identified by PETs than with other imaging strategy? It's bone, or we don't know?
Yeah, I think it's all. So I do not have figures specifically for small cell lung cancer, but as it is a hypermetabolic tumor, also in a metastasis, I would presume that it's also the bone. So except for the brain, where MRI is the preferred diagnostic tool, I think it's has higher sensitivities and specificities than conventional staging with CT or bone scintigraphy.
Maybe the last question, do you have some difference in terms of preference between histology or cytology to make a diagnosis for small cell or for molecular analysis?
Well, if we want to have, it is always, if we have cytology, of course, we have cytologic blocks of cells. So it is quite convenient for any analysis, but we prefer to have histological samples. So a biopsy sample, which is quite enough to perform all the analysis that we want to consider.
So there's a question of clarification about the NGS indication in small cell carcinoma. No indication, because it is an emergency and you have to begin as quickly as possible chemotherapy, but you have to wait or not to wait if a patient is a non-smoker, only if it's not smoker, and sometimes with a composite tumor, but probably the first line treatment will be a chemotherapy based on the etoposide on the platinum. Torsten Draganel, you want to comment about that?
Fully agree.
Okay.
Yes.
Okay, I think we have to continue because we have a lot of work to do. But thank you for the question, everybody.
Yeah, but I think that's interesting. So maybe we will need some extra time, but I hope that's fine. So now to the therapy, and we are the very limited disease. So these are the tumors with CT1-2. No healer or mediastinal metastasis, no distant metastasis, which corresponds to clinical stage 1 to 2A. So one cornerstone of the diagnostic should be the mediastinal staging, as you can see here. If it is negative, the patient is fit. Then it's recommended, and this is not only NCCN, I think this is stated in almost every guideline, to go for surgical resection, anatomical resection, preferably lobectomy. If not, if the patient is medically inoperable, but the staging, mediastinal staging is negative, you could go for stereotactic radiotherapy. Very important is the adjuvant therapy part in this little cohort, less than 5% of all small cell lung cancers who could qualify for surgical resection. So if you have performed surgical resection, at least there should be, or in all cases, there should be systemic therapy. So if there are no local regional lymph node spread, then systemic therapy alone is sufficient. If not, if you have hilar or mediastinal metastasis, you should also add mediastinal radiotherapy. So this is really a cornerstone of the therapy, and as you can see, more aggressive than in small cell lung cancer. This is a very recent study from Young and colleagues from 2018, showing here in the Kaplan-Meier curves a clear survival benefit of patients in very limited small cell lung cancer if they receive surgery compared to concurrent chemoradiotherapy, which could be an alternative. And very interesting, as I said, it should be at least lobectomy. That's the green Kaplan-Meier curve. This is improved. And here you can see if you go for wedge segment resection, then you have a much poorer overall survival. So one quick question to you: what would you recommend in a fit small cell lung cancer patient? Clinical stage CT3, so it's a larger tumor, primary tumor, 5 to 7 centimeter, but no local, regional, or distant metastasis. So would you recommend surgical resection, or would you avoid surgical resection and instead go for concurrent chemoradiotherapy? So please choose your option. Yeah, and I think based to NCCN, they somehow favor both options. You can choose. That's something that you can discuss with your patients. So you may go for surgical resection, but you may also go, as I can show you here, when it comes to CT2 up to CT4 patients without metastasis, or even then patients with local regional metastasis. So they are also belonging to the limited disease group, but for the CT3N0M0 group, you could also, of course, go, and then that's the standard of care, should be the standard of care in patients with good performance status for systemic therapy plus concurrent radiotherapy. So whenever possible, this should be your goal. In patients with a poorer performance status, but due to the small cell lung cancer, so think of perineuroplastic symptoms, for example, the recommendation is also systematic therapy plus radiotherapy, concurrent or sequential. But if the performance status is diminished, not caused directly by the small cell lung cancer, then you should think about individualized treatment concepts or best supportive care only. So these are the recommended regimens for the chemotherapy regimens for the limited stage small cell lung cancer. You can see it in the slides afterwards. So for the matter of time, I will skip this. But come to an older study showing a benefit of concurrent chemoradiotherapy over sequential chemoradiotherapy in limited disease small cell lung cancer clinical stages 2 to 3C, as you can see here. And this is the study by Corinne Finn, which assessed the effects of twice daily radiotherapy compared to once daily radiotherapy, which I think is more or less the standard in Europe, concurrent with chemotherapy. And this is recommended to up to 6 cycles of cisplatin plus etoposide. And this study, and also according to the study design, as you can see here in the hazard ratio, then you can see that there is no significant difference, so there is no clear effect pointing in one direction or the other. So I think it's appropriate also to still go for the once daily radiotherapy in combination. But you could, of course, also think of twice daily radiotherapy. And as you can see here in the side effects, there is no significant difference among the two study groups. So now we move on to the extensive disease, small cell lung cancer. That's a more complex scheme. I will focus here at the top part. So you have extensive stage small cell lung cancer without localized symptomatic sites or brain metastasis at the beginning of the therapy. And if you have patients with a good performance status, or the performance status is reduced only due to a direct effect of the small cell lung cancer, then the clear recommendation is a combination systemic therapy, and this is chemotherapy plus immunotherapy. And of course, as we speak of extensive stage, you should also think of applying supportive care, or also introducing palliative care measures early. If the performance status is altered, not directly related to the small cell lung cancer, again, you should think of individual treatment concepts. If there are any imminent local complications like superior vena cava compression, spinal cord compression, then it's always an individual decision what to treat first. I think you have to judge individual, and this is clearly a place for proper MDT teamwork. So for some years, the checkpoint inhibitors have also found their place in small cell lung cancer treatment. As we remember, in 2015 in Europe, they were approved for second-line treatment in non-small cell lung cancer. The principle of are the immune checkpoints, are the somehow sleeping T cells. So the immune system is somehow incompetent tolerating the tumor cells as antigens, and this is triggered within the tumor microenvironment via the PD-1, PD-L1 axis, or a bit more distant via the CTL4 axis. And for all those, for the CTL4, you have specific inhibitors, so-called checkpoint inhibitors. The first ones were the PD-1 inhibitors, nivolumab, pembrolizumab, and then the PD-L1 inhibitors, atezolizumab and durvalumab. And they have, over time, have been also introduced into small cell lung cancer treatments. Now recommended in combination with standard chemotherapy, and here you can see a very recent systematic review, and the currently recommended combinations made up of immunotherapy, checkpoint inhibitors, and standard chemotherapy with a platinum doublet with etoposide, atezolizumab and durvalumab. Remember the PD-L1 inhibitors. Also in combination with tremelimumab, that's another CTL4 inhibitor. And as you can see here in the forest plots, they favor the combination of immunotherapy and chemotherapy over chemotherapy alone. There are other substances like nivolumab. This was only a phase 2 trial, very recent one, but so far nivolumab is not has not been approved for that, whereas pembrolizumab has also shown a significant effect in terms of overall survival. Here are the pooled side effects, and interestingly, the control arm, these are composed of the chemotherapy only treated patients, as well in the intervention arm, immunotherapy plus standard chemotherapy. You have a large proportion of side effects, so almost 1/2, but in both groups and not significantly different. Luckily, a low number of lethal complications. And the only complication that was significant was colitis grade 3. This was, but it was higher in the control arm compared to the experimental arm based on this meta-analysis. Here you can see the recommended treatment concepts for extensive stage small cell lung cancer, at least here in Germany, but I don't know where it is, how it is elsewhere. We do not use irinotecan in combination with platinum in first-line treatment. So here are our favorite treatments that we currently apply here in our center, but also I think in the majority of German centers. This could be still an alternatives in patients that are not fit for immunotherapy. Very important is the follow-up of patients, and I would like to draw your eye on this point here. So if we have patients with extensive stage disease who have a complete response or partial response in the combination therapy, you should consider thoracic radiotherapy as a consolidation part within your treatment concept. And there's good evidence, also older one from 1999 and also 2012, showing an added value if you apply consolidating thoracic radiotherapy after the treatment. Okay, so I don't know what the time is, but I would be happy to have some discussion now.
The problem is that we have very few times, and I tried to discuss with Ali to prolong, but I think he doesn't want. Okay, maybe you can imagine a second webinar for the advanced disease. There are many questions. The first one, but very short answer, please, Torsten, is from Jan van Berg, that he asked you about the choice of the NCCN recommendation rather than ESMO or ASTRO. A few comments about that, very short.
Very short. So I think NCCN is the one that is most frequently updated, and for me the methodology is more solid than the one from ESMO. But ESMO is fine as soon it's not updated so frequently.
It has been just recently updated.
Yes, I know.
Yes, I know that you.
May I comment on surgery
yes,
just for a second?
Yes.
Just to say that, in fact, in these newly released ESMO guidelines, also there is a place for surgery in limited stage. So it is in stage 1 and 2, and also if we have mixed histology. But I would like also to say that these results of the studies on surgery in limited diseases are not so controversial anymore. There is a Cochrane analysis from 2017. There is also retrospective analysis from 2019, ZAO, and also a national database from Wacom 2017 that has shown highly significant advantage of surgery. Median overall survival was 48 months versus 28 months. So that's why there is still debate about surgery in limited, very limited. But it is just the choice of the institution and the possibility.
I was very surprised. I was very surprised that the result was 50-50. I beat majority for the chemoradiotherapy. But in my opinion, the size of 5 centimeters, I think, is big. 4 to 7 centimeters, I think it's big for surgery. In my opinion, this patient would have a diagnosis of small cell carcinoma before. And if I have this diagnosis, I'm not sure that that I in first line begin by the surgery. Maybe I made maybe 2 cycles of chemotherapy. Then after, maybe rediscuss about the place of surgery. And the question, I think, in my opinion, the place of surgery is that after surgery, if you have a complete lymph nodes excision and it's negative, do you give radiotherapy or not after surgery? Of course, you will be given chemotherapy, but will you give also radiotherapy if the lymph node is completely cured?
If we have completed, for example, limited disease surgery, then we give only systemic treatment. If the operation is lobectomy, because it is the condition to be the most lobectomy with mediastinal lymphadenectomy. So that's how we do it.
Yeah, I think it will be always in this circumstance individual concepts if you think of surgery. So even as discussed in the chat, is it really worth going for neoadjuvant chemotherapy? So yes.
Okay, I think the option that is proposed by Ali is to organize a second webinar, rather than to be too much quick now, and maybe to continue about localized disease, not to PCI. If you agree, Thorsten.
Yeah, that's fine for me. So I think everybody will access to the slides. So I mean, we can, if I've just read, we have some 5 extra minutes.
Okay.
So let's discuss about the treatment. And well, one colleague stated that ESMO, for example, coming back to the T3 tumor, clearly recommended only concurrent chemoradiotherapy. NCCN was somehow more open, so they at least well, provided the option to go for surgery. I think here we would be still more conservative. So we would discuss this option with the patient, but would be somehow reluctant. But if you have, sometimes you have really young patients with small cell lung cancer, and well, then sometimes you think.
There are 2 important questions. The first one is on what is your first treatment in case of Cava syndrome? Do you prefer chemotherapy first or radiotherapy first? I think it's an important question. And the other question is about the PES, the performance status 3 or 4. Could you precise your comment about that? So first, radiotherapy or chemotherapy in case of Cava syndrome?
If you ask me, if it's emergency, then radiotherapy has shown an excellent results. Within 2 weeks, we see the result. But generally, also systemic chemotherapy is of utmost importance.
Yeah, same here. But we would also think about stenting the
yes.
Cava.
Yeah.
Good option. Very good option.
But sometimes you have problems. So if the compression from the so we had one patient that became a cardiac emergency because the stent dislocated into the right heart. So this was really a problem.
Could you elaborate more on systemic chemotherapy for patients with PES 3 and 4?
Well, I think the most important question is what is the cause of the reduced performance status. So, for example, I said if it's perineuroplastic syndromes, or maybe sometimes you have a very extensive or large liver metastasis, and you have a good response. So I think then you can think of a salvage chemotherapy. but these, I think this is somehow well stated in the NCCN guideline, are always individual treatment concepts. So I think you have to see the patient. You need to know about the preferences of the patient, but you also have to see the medical conditions, which is sometimes complex.
Okay, so the proposal of Ali from the ERS is to close the session in few minutes, but to propose you a second webinar that will be deal on extensive disease, palliative care on PCI. Are you okay, Torsten and Dragana?
Yes.
Because the work is done. So
yes.
This
works on the night.
This was my strategy. So
yes.
Sorry, but I think we have had some good discussions. Unfortunately, I haven't seen all the comments from the chat, but well.
The other comment will be on the PCI, so you don't see the doubts. And I think we can close on it. Very happy, very fruitful webinar on a lot of questions. So it's very exciting to have a second one. And the work is done and the slides are done. So we are waiting with Ali to have an agenda for a second webinar, not too late, because people are on this activity now. Okay.
Okay. So, but the next webinar. So maybe we can just briefly show the slide. No. I think it was 12th of June. It's advertised on the channel from the ERS, and please join there. And then it's small cell lung cancer, neuroendocrine tumors other than small cell lung cancer.
Okay. Thank you so much to everybody. It was an excellent session and very interactive. And we will soon give you another date with this excellent jot with Dragana and Torsten. Thank you very much.
Thank you very much.
Bye-bye.
Thank you. Bye-bye.